So I think we have a mixed audience here. So my talk will include some basics and also some, of course, we will cover the details. So I hope there's something interesting for everyone and you will find it interesting and exciting. There are 4 valves, as we know, and 3 of them cause problems in adult patients: the aortic valve, the mitral valve, and the tricuspid valve. We now move on to secondary or functional mitral regurgitation, where the mitral valve apparatus is actually normal, but the primary pathology is that of the left ventricle, the heart failure. And in this diagram, you can see that the heart has dilated due to heart failure, due to dilated cardiomyopathy. And because of that, it has pulled the papillary muscles and the chordae, which supports the mitral valve leaflets, leading to what we call tethering of the valve leaflets. And because there's no coaptation between the leaflets, there then is significant mitral regurgitation. So the management of these patients are very different from the management of patients with degenerative mitral regurgitation, because here the primary pathology is that of the left ventricle and heart failure. So the treatment of this has to then focus on the treatment of the heart failure. So this is a patient who I saw about 2 years ago now. He's 56 years old, and he had got breathless from malexertion. He used to be able to play golf, and he can't play golf anymore. He had some degree of pulmonary edema. His NT-proBNP was 12,000. And you can see that he had severe LV impairment. His ejection fraction was 20%. The heart was dilated with a systolic diameter of 57 millimeters, diastolic diameter of 63 millimeters. And you can see he has moderately severe functional mitral regurgitation with an EROA of 0.3. You can see the 2 leaflets are particularly restricted because the ventricle is so big and not contracting very much, and there was significant mitral regurgitation. The coronary angiogram was done, and the coronary arteries were normal. So we have a question for you again. How would you manage this patient? Optimize medical treatment, or recommend a mitral valve repair or replacement in addition to optimal medical treatment? Oh, we're a bit divided. Okay. So we're split 50-50. Okay. So let's go on, and hopefully we can get some answers. So the aims of any intervention and the aims of intervention in secondary mitral regurgitation is firstly to improve survival, and secondly, of course, importantly, to improve their quality of life and their symptoms, and thirdly, to avoid hospital admissions. So the problem in this case is that the heart failure is the primary pathology. It has in turn caused a volume overload from the leaking heart valve. So there's sort of a vicious cycle where the mitral regurgitation would cause progressive worsening of the heart failure. But in this condition, because the primary pathology is that of the heart failure, it is important to optimize them first on the heart failure medications. So they optimize their beta blockers, their ACE inhibitors, their angiotensin receptor neprilysin inhibitors, the MRAs, and the SGLT2, and to optimize them for at least 3 months, to watch for a response. And during this time, monitoring them closely, assessing whether they're responding to medical treatment clinically, and also by the markers such as the NT-proBNP and echocardiography, before considering other options, because they may not need the other options. This medical treatment may be sufficient to improve them. And if they are not responding to medical treatment after 3 months, then they are unlikely to respond. At that stage, you could consider further interventions from CRT, for example, if suitable, if they've got desynchrony or widened QRS on ECG, or valve surgery or device surgery, and other antiarrhythmics or an ICD. So this patient was optimized on a beta blocker. He was started on an angiotensin receptor, neprilysin inhibitor, and ARNI, spironolactone, furosemide to offload him a bit because he was in pulmonary edema. He wasn't on an SGLT2 inhibitors, but he is now, after the evidence came out of the improvement in survival with SGLT2 inhibitors. So he was optimized on this, and he was monitored. And at every 3-month intervals, more frequently initially, but at every visit, he showed improvement in terms of a reduction in his NT-proBNP and his symptoms. And so he was maintained on medical treatment. So there's some data from the Paradigm Heart Failure trial, which shows that when you initiate treatment with either an ACE inhibitor or with sacubitril valsartan, there is a significant drop in NT-proBNP within about 2 weeks. And this reduction is sustained in the case of the sacubitril valsartan, but it's much better compared to the traditional enalapril ACE inhibitor. And when we look at this more closely, the dosage, the optimal dosage of the ARNIs is important. The optimal dosage is 200 milligrams twice a day. It may not be possible to start them on 200 milligrams twice a day straight away because there may be a bit of hypotensive. The renal function may be a bit borderline. So a lot of us would be cautious and start them at perhaps 100 milligrams twice a day, or even at 50 milligrams twice a day. But the important thing is to slowly titrate this upwards towards the maximum tolerated dose of 200 milligrams twice a day in order for it to exert its maximal effect of reversing the left ventricular remodeling. And this is a trial, the PRIME study, specifically looking at patients with functional mitral regurgitation, which did demonstrate that at 12 months with the sacubitril valsartan or Entresto, there was a significant reduction in the severity of mitral regurgitation, more so than those who were just treated with valsartan. The PRIME trial was a randomized trial comparing valsartan alone versus sacubitril valsartan in patients with functional mitral regurgitation and a dilated left ventricle. So this patient was maintained on that, and we were targeting medications which would hopefully interrupt all of these processes and not only interrupt it, but reverse it, and leading to reverse remodeling of the left ventricle, and in so doing, hopefully to prevent sudden cardiac death. This is 2 years later, so you can see that the patient is now asymptomatic. That same patient, his NT-proBNP had reduced to 280. His left ventricle improved significantly to EF is now 56%. The LV is in fact a normal size now. LV systolic diameter of 37 millimeter, end-diastolic diameter of 53 millimeter. The mitral regurgitation was mild in severity. He's now on the Entresto of 200 milligrams twice a day, bisoprolol of 10 milligrams once a day, spironolactone, and dapagliflozin. It is important, in my view, that even though the left ventricle has been, the heart is now of a normal size and function, that we maintain them on the heart failure medications. But we could perhaps discuss this in the question and answer session. But this patient has done very well just from medical treatment, and there are quite a few other examples of these patients who have responded remarkably well with just medical therapy. So this is just to compare the same patient. The top row shows what he was like 2 years ago, and the bottom one shows what he's like now 2 years after medical therapy. Now, but of course, not all patients will respond in this way. He is very fortunate. But as I said at the beginning, it's important to optimize their medications for at least 3 months and then evaluate. And if the trend at 3 months is that they are improving, then to persist with medical treatment. But if they are not, then we have to consider the options. And then that depends on a few things. The severity of the mitral regurgitation is one of them. So if we have improved their mitral regurgitation to at least mild, then there is definitely no indication for any intervention of the mitral valve. If we have reduced the severity of mitral regurgitation to moderate, then it is debatable what we do. There is still an intermediate risk of them having heart failure, hospitalizations, and progressive LV and LA remodeling, and a high risk that the mitral regurgitation would progress again to severe. But I think if the mitral regurgitation improved to moderate, we would not then at that stage intervene on the mitral valve, but only if the mitral regurgitation remains as severe or moderate to severe, then we could consider some intervention on the mitral valve. Because if we left the patient with just medical treatment and moderately severe mitral regurgitation, then they are still at a very high risk of needing hospital rehospitalization, progressive mitral regurgitation, and also sudden cardiac death. So one of the options to offer patients who are not responding to medical treatment mitral valve repair surgery or mitral valve replacement surgery. And this is one of the studies which showed that you can do it at a low operative risk of 1.6%. And this is the results after mitral valve surgery. You can see a significant reduction in LV volumes and an improvement in their ejection fraction. And if we compare this towards patients who just have medical treatment, you can see that patients who have mitral valve surgery show a much significant improvement in terms of their reverse LV remodeling and reduction in LV volumes. We can also look at the trials on using the mitral clip. The mitral clip is a device closure of the mitral valve. In this case, this is the mitral FR trial, a randomized trial comparing optimal medical treatment against optimal medical treatment plus the mitral clip. In this case, they demonstrated no difference in terms of their endpoints of all-cause mortality and unplanned rehospitalization for heart failure compared to optimal medical therapy. In contrast, this is another trial, the COAP trial, which looked at the same thing, and they also randomized patients with significant mitral regurgitation and heart failure to either continuing on medical therapy or having a device closure of the mitral regurgitation. And in this study, they showed that those who had the device closure of the or the device correction, the mitral clip of the mitral regurgitation, the hospitalization for heart failure decreased by about half, and their survival also improved. The death from any cause was reduced significantly in those who had the mitral clip compared to those who remain on optimal medical therapy. So the differences in results from these two studies is almost certainly due to different selection of patients, and it is thought that we have to look at a few parameters, and that functional mitral regurgitation is a bit more complex than just randomizing all these patients to medical treatment or intervention of the mitral valve. And there are really various categories of these patients which we need to consider, and we have to individualize the treatment to each patient. And we will go into this into a bit more detail in the next during the presentation. But one of the things which appear to be important is to look at the proportion, the severity of the mitral regurgitation and how proportionate it is to the dilatation of the ventricle. If you have a ventricle which is very dilated and the severity of the mitral regurgitation is in proportion to the dilatation of the ventricle, then it is likely that these patients would benefit with just medical treatment, and that correcting the mitral regurgitation may not be that advantageous. But if the severity of the mitral regurgitation is disproportionate, disproportionate to the degree of dilatation of the left ventricle, then it may be advantageous to correct the mitral regurgitation in these patients. So what we have seen in this example are very much patients in this group, patients with heart failure, reduced ejection fraction, or moderately reduced ejection fraction, where there is dilatation of the left ventricle causing leaflet restriction, some degree of dysynchrony, impaired LV contraction, lack of mitral valve leaflet coaptation, and this then results in mitral regurgitations with increased LA pressures, increased LV filling pressures, decreased contraction of the mitral annulus, and mitral annular dilatation. We can also get secondary or functional mitral regurgitation in those with preserved ejection fraction. This typically occurs in patients with atrial fibrillation. In chronic atrial fibrillation, you can get dilatation of the left atrium, and this results in dilatation of the mitral annulus without impaired contractility of the left ventricle. And so in these patients, you can get significant mitral regurgitation just from annular dilatation. Now, if that's the case, then in those patients, there is limited role for LV reverse remodeling or heart failure medications, because the left ventricle is normal in those patients. So those patients would benefit from valve repair surgery, and to correct the mitral regurgitation in those group of patients, we will just put in an annuloplasty ring. We have to put in an annuloplasty ring which is a bit smaller than the size of the normal annulus, what we call a reduction annuloplasty or an undersized annuloplasty, to improve the coaptation between the two leaflets of the mitral valve and to correct the mitral regurgitation. Some time ago, I had the opportunity to study in detail the normal annular and leaflet motion of the mitral valve during the normal cardiac cycle. And our cardiologists will know this from echocardiography. But if you look at it in detail, and this was a study using cardiac magnetic resonance, the mitral valve annulus is a dynamic structure. It gets smaller and bigger throughout the cardiac cycle, along with the mitral leaflets. And you can really divide that into 6 phases of the cardiac cycle. And the mitral annulus is smallest at the pre-systolic contraction and gets larger just before the onset of diastole. Now, this normal annular function of the mitral valve is lost in functional mitral regurgitation, as we can see here. This is in a normal healthy patient, where you can see the size, the subtolateral diameter of the mitral annulus changes in size during the cardiac cycle. But in patients with functional mitral regurgitation, that annular contraction is lost. And this is again one of the mechanisms which contributes to mitral regurgitation in these patients. And that is another reason why we would put in a mitral annuloplasty ring, which is smaller than that actually size, to compensate for this loss of mitral annular contraction. Thank you for participating, for joining us today. Thank you again to Novartis also for organizing this. I'm happy to take any questions if you have any. Thank you very much.